Well, good afternoon, everybody. My name is Jeff Micklos. I'm the Executive Director of the Healthcare Transformation Task Force, and I'm particularly thrilled to be able to moderate this panel today because I think the way Sean and the team has set up the agenda today, it's really important to focus kind of at that last stage on the employer and the commercial market. We know that there's so much going on in the CMMI space, the CMS space. We just heard in the prior panel on how ingrained in the model value equity is for community health centers, where I think personally see a greater challenge is in the employer in the commercial space. And so to give you a background for that perspective, I'll just tell you that Healthcare Transformation Task Force is a private sector consortium. It's made up of providers, payers, purchasers, and patients. And our organizations are committed to making the move to value, whether it's advanced primary care or whether it's in accountable care, other types of models. And I think in the 7 years of our existence, we've seen the greatest challenge in the commercial space to date. And I think a big part of that is because when we talk to our payer members about it, when they look at their commercial book of business, 80% of that is self-insured. And so even as they mature and they develop a product in the value space that they'd like to offer, they're often met with a self-insured plan that says, well, that's not quite right for us. And so then they tend to focus on other spaces. And so my observation would be that the purchaser community writ large has not been the demand driver we'd like, but I'm really happy about today is because we actually have a panel that really are on the opposite side of that, and I'm really excited for that. So I'll go ahead and do brief introductions, and then we'll kick off the panel. So to my far right, we have Jenny Goins, who's the President and CEO of the Kentuckiana Health Collaborative. In the middle, we have Dr. Patrick Aguilar, who's the Chief Medical Officer with a venture called QuikMed, which was launched in 2020 by Tulsa-based employer QuikTrip. And then to my immediate right, Bret Jackson, who is the president of the Economic Alliance for Michigan. So welcome to all of you. What we'd like to do is start with a level-setting question. I'm going to ask each panelist to talk about their individual organization, what they're currently doing in the primary care benefit space, and also offer some other personal observations from prior positions, because you all are very well steeped in the place. So I'll start to my immediate right, and Bret, we'll kick it off with you.
Yeah, thanks. And I want to thank Sean and Primary Care for America for the invitation today. I really appreciate the opportunity to come and share the employer and purchaser perspective. As was stated, I'm president of the Economic Alliance for Michigan. We are a labor and business coalition, meaning I have as many labor unions as I have employer members as part of our coalition. Together, our members represent about 900,000 covered lives in the state of Michigan, about 2.4 million nationally. And if you combine my coalition with Jenny's and about 40 plus other coalitions that are part of the National Alliance of Healthcare Purchaser Coalitions, we represent about 45 million Americans who spend $300 billion on healthcare. And so our stake in the future of healthcare in America is important. And I'm going to start off by sharing where our perspective is as purchasers in the commercial market that I think may be relevant to you. Most employers know that they spend a lot in healthcare, and they really have no idea where the money goes. And when we look at healthcare generally, from the seat that I'm in, we spend $4.1 trillion in healthcare in the United States. That is the fourth largest economy in the world, behind the United States, China, and Japan. Germany, United Kingdom, and every industry in those countries is a smaller gross domestic product than our US healthcare system. And so when we're approached and to say, hey, listen, we need you to invest in primary care and look at all the data that's out there and the studies that show how beneficial it will be for you and your employees and their beneficiaries, we say, yeah, we're in. And then they say, okay, great, give us more money. And we're like, wait, what? We just gave you a lot of money. I can look at my books and say how much I spend in healthcare each year, and it's a lot. And they're saying, but a little bit of it goes to us, and a lot of it goes to other people. And it's like, well, I don't have any more. My CFO looks at the healthcare line item as an expense, not necessarily as an investment. There are companies that do look at it as an investment, but a lot of companies just look at it as an expense. We don't have any more money. In fact, we're being asked for how do we find ways to cut back? And so what I want to say most importantly is we're with you. We want to be partners in investing in primary care, but we got to figure out ways to do it together, as other panelists have said earlier today, to find out, with all the money we have in the healthcare system, how do we distribute it in a way that leads to the outcomes, the better outcomes that we want to see. And so when we look at primary care, from my standpoint of the Economic Alliance for Michigan, we have three key areas. We're looking at system change, first and foremost, and I think that has to start with payment reform. I think there's so much talk today about the workforce issues, and I totally agree we have to tackle the workforce issues, but if we take care of the structural components of how we pay people, I think some of those workforce issues will be dealt with over time. And we also want to see a movement towards advanced primary care, including integrated behavioral health. That is very important for our members. The second big bucket is patient experience. When we are thinking about how our members and their families are interacting with the healthcare system, what their experience is like going through the healthcare delivery system is as important as anything, because the better they feel about their care, the more trust they have in their care, the more likely they are to repeat, to develop relationships, to look at their primary care physician as the first place they go to when something arises. They want the ability to access things easily, quickly, and you all know this, I'm speaking to the choir here, but they also want a doctor that they can relate to. Maybe the doctor looks like me, and I'm not just talking about race or ethnicity. I represent a very multi-generational workforce. In fact, some of my workers are in the 50 to 65 range. Are they going to trust a 20-some-year-old doctor to take care of them? Maybe. But more likely, they're going to want people who look like them, whether it's gender, race, ethnicity, and even age. We want to make sure in the patient experience that handoffs happen seamlessly. And obviously, we think about specialists when we think about the handoffs and handbacks, right? We want there to be a two-way street. We want the physician, their primary care physician, to be the quarterback of the person's life care. But we also want to make sure we include all of the different vendors that an employer works with. I have companies who, on average, work with 25 different vendors. How do I make sure there's connectivity between everybody? And that the patient handoffs from the diabetes vendor go back to the primary care delivery system, and that they can use those tools seamlessly in a way that makes it easy for the patient to navigate. And then the last thing that we work on is increasing primary care engagement. Too many of our members specifically use the ER as their primary place to get care. And what drives me nuts are the billboards on the side of the road that say, 9-minute wait. And if I call my primary care physician and it's like, okay, we can get you in next week, or I've got 9 minutes to wait, what am I going to choose? Yes, there are some financial barriers to going to an ER versus going to my primary care, but for some of my members, there aren't. We have some union plans that are very rich benefits that offer first dollar coverage no matter where you go. So what is the patient going to do? What are they going to choose? They're going to choose what's convenient for them, what they feel comfortable with, what they know they can access care quickly and efficiently with, from their perspective, right? It's definitely not quick and efficient for us. And just this week, Henry Ford Health System in Michigan announced a partnership where they're going to be opening 15 urgent care clinics around the Metro Detroit area. That also scares the heck out of us. When I read that, it just drives me absolutely crazy, because we're not then investing in the places we need to invest in. We're investing in higher cost, siloed parts of care that are not adding to the benefits of of the healthcare delivery system. So I'll go into some specific details of what some members of mine are doing and really great innovations that QuikTrip is doing, but that's just an overview of our perspective.
Thanks, Bret. Dr. Aguilar?
Thanks. So I really appreciate the opportunity to be here as well. Nice to hear all of the great things that are happening around the country in this space, and excited to share a little bit about what we're doing. I mentioned yesterday I'm an academic pulmonologist by background, so I'm trained in internal medicine and then did pulmonology and worked at WashU. And I'll tell you that the day that I called the chairman of medicine at WashU and said, hey, I'm leaving WashU and I'm going to work at QuikTrip, was a really interesting experience for me on a professional level. I think she's, could you say that again, please? This doesn't quite fit. But I'm really excited to get to do what I do. I have probably the coolest job of anyone anywhere. So yes, I'm bragging. It's an awesome job and I love the company I work for. So I'm going to brag about it while I talk about what we're doing in primary care. So I get to be the chief medical officer for our health plan and our primary care arm that faces our employees and their families. We also have a community public-facing health innovation space that we're working in. We are working in urgent care, so as a disclaimer, we do some of that stuff as well. But for today, I'll just focus on what we're doing with our employees. In the late 2000s or early 2000 teens, and I shouldn't assume you know, QuikTrip is a massive convenience store chain that stretches from Phoenix to Atlanta. We have, as of the last week, 942 convenience stores and something like 25,000 employees across all that territory. We've primarily centered ourselves in large urban markets, Dallas, St. Louis, Kansas City, Phoenix, Atlanta, and so on, but we've started expanding into other communities where we may only put one or two, and we're trying to figure out how to make that work and make all the other things we do to support the business work alongside that. In order to make things work for the company and to grow the company, the primary focus forever since it was founded has been on helping employees grow and succeed. There's actually, when you walk in the front door of our corporate headquarters, there's a giant vaulted ceiling and a huge poster that says the purpose of QuikTrip is to provide our employees opportunities to grow and succeed. And so that concept of support the employee and they'll support the patient, or the customer in the case of a convenience store, that concept is really baked into everything we do, and it's incredibly important to us that the things we do are designed to help our employees actually feel like they work somewhere that cares about them, because we believe that that's the way that they're going to help customers feel like they're in a place that cares about them, and that's what's going to get people to come back. So in the late 2000s, early 2010s, QuikTrip decided to form its own fully self-administered, self-insured health plan and did exactly that. They recruited the guy who's now my boss to come in and figure out, how are we going to put this together? How do we pool our risk together? And how do we create what amounts to something like an HMO with narrow networks of partnerships with health systems in all of our major markets? So that was done. And then shortly thereafter, there was a partnership formed with a private direct primary care company that was separate from us. And we used that partnership for roughly a decade, and were able to provide lots of primary care at no cost at the point of care to the employees and their families. That went on for a good 10 years and was a solid partnership, but as we have done with many of the things that we do at QuikTrip, we made the decision we could probably do this too, and we could probably do it the way we want it done, consistently and in a manner that actually gives more of our employees more opportunities to grow and succeed and so on. And so in 2020, I came on for the public-facing venture with the awareness that something was happening with our employee health program as well. And in early 2021, I took on the CMO role for what we're doing for employees. We rolled our first clinic over from the private vendor into our own hands in May of 21, and we rolled the last one over in something like February of this year. So it's been kind of a whirlwind. We presently have 14 clinics with 20 providers stretched out across the major markets that I outlined a second ago. And we see patients same day or next day when they want. We can book follow-up appointments, obviously, and we have family medicine providers who are in the clinic available to handle the full comprehensive primary care approach. We do allow our patients, our members to use community pediatricians for vaccines, because our number of sort of how much vaccines we can use in a given period per clinic doesn't justify maintaining a stock of vaccines and making sure the refrigerator is the right temperature and all that. So well-child checks with the pediatrician inclusive of vaccines are done outside of our practice, but the rest of primary care really does live right within what we're doing. And so why do we do this, and what are we thinking about when we put something like this together? I'll be very cheesy, and if anybody in here ever worked at QuikTrip, you're going to feel right at home right now, because I'm going to cite one of our core values, which is kind of a silly thing to do, but it's extremely relevant. And the core value is focus long term. I didn't tell you this yet, but QuikTrip is a privately held company that has a founding family who still controls the majority of shares. And so when they define value, to your point about seeing healthcare spend as an investment as opposed to a just line item cost, when they define value, they do not look at value, that the family does not look at value in the quarterly earnings report way. They look at it in the where will this be in 10 years way. And that means when I say I have the coolest job, it's because we have lots of these kind of levers that are in there to make it easy for us to do things that make sense in the long run and not have to worry about what that's going to look like on our next quarterly earnings report. And so focus long-term for us means let's think about what it's going to do to health plan spend when we actually improve access to primary care and do things in a way that cause people to want to use our primary care system. And that has led to pretty substantive reductions in spend elsewhere in the plan. And we've been able to control lots of costs by having disease management sit right within a set of clinics that we now administer ourselves. That's been a very cool outcome of the investment, but it did take a couple of years for that to start to be obvious. And so that focus long-term idea really has to be in the mind of an employer who's thinking about doing something like this. The other thing that I think really comes to play is that poster that I told you about a minute ago regarding making sure that there are opportunities for employees to grow and succeed. Growth and success at QuikTrip sometimes means pay raises, sometimes it means new jobs, but it also often means sort of development. There's a huge emphasis on human development and on helping people who work in our convenience stores learn skills that are translatable and applicable elsewhere in their lives. And one of those things is health promotion. And so we have a personal health assessment that everybody has access to. We push that. If you're an executive, they require you to take it. And if you go kicking and screaming because you think I'm a doctor, I don't need this, you sometimes find out that your LDL is like 1 billion. And so it's actually pretty good benefit to get that. And we support it and we push it to all of our members and really try to get people to do that. That opportunity to grow and succeed also means keeping that kind of relationship and keeping that connection with a physician, nurse practitioner, or PA who is consistent, who you know, who's connected to you, and it's something that we really emphasize. A selling point that I really like about the QuikMed movement, moving away from our outside vendor towards our internal QuikTrip primary care program, came up kind of serendipitously while we were planning the announcement to the staff. And what we decided is if we're a company that absolutely wants customer service to be the name of the game for us, and it's how we win, is we're going to have great, nice people who sell you your soda really quickly and get you in and out and treat you nicely while you're in the store. We should offer our employees that as well when they interact with us, and in particularly when they interact with us regarding health promoting activities like visiting a primary care doctor. In our prep call for this meeting, we were just sort of bantering about and thinking, why is it? Because I told you it's no cost at the point of care for our members. Why don't we have like 100% utilization and people banging down the door? And I think you can really reduce that, in our case, to a design problem a couple ways. One, the location may not be convenient. And if somebody has to drive 30 minutes for something free or 5 minutes for something that costs beneath their willingness to pay, they're going to often make that kind of calculation and do what's more convenient. And so this year we introduced 98.6, which is a telehealth primary care vendor, as a supplement. So it's something they can have access to. We still want to promote the use of our primary care clinics so those relationships can get formed. But we want people to have access to care at some level, even if it's not necessarily always optimized to what we think is best. The other design problem could be that the experience of obtaining care is really unpleasant. I think we can all remember times we visited a clinic and wished that we had never stepped foot through the door for one thing or another. I can think of lots of services that I've used where I've thought, this was unpleasant, I'll not do this again. And we have, as a society, as a system, I don't know what malevolent other I want to pin this onto, but in the universe in which we live, the access to healthcare is very often something that is constructed essentially to be unpleasant. And it's not the fault of the provider who's sitting across the table from you. It's the natural consequence of a set of rules regarding payment, necessary economics to get people taken care of, regulatory structures that mean there's all this stuff you have to put in this computer system that then becomes the dominant thing that draws your attention instead of the person across the table. That stuff has constructed a pretty negative experience. And so our hope is that because we own this and can do whatever we want within some rules, we can actually try our best to make this a positive experience. And so that's a place where we spend a lot of time thinking, how do we make this match what our employees would want, just like we want them to match what the customers want in the stores. So that's where we've come from. That's what we're doing. That's kind of where our focus is, and I'm happy to keep the discussion going. Pass it on to you.
Okay, thank you. I'm Jenny Goins, and I have the privilege, I'm also one of those folks that really loves my job. I have the privilege of being the president and CEO of the Kentuckiana Health Collaborative, and you're probably thinking, what in the world is that? And that is another coalition, like Bret talked about. We are focused in Kentucky. We started out in Louisville, but we're focused in all of Kentucky, in a couple of counties in southern Indiana, across the river from Louisville, and it's considered kind of the metro area of the Louisville community. Our focus is on making sure that we, in our communities, have access to quality, affordable, and equitable health care. Our members, unlike Bret's, where in most of the coalitions who belong to the National Alliance, where it's totally employer-based or UAW, or union-based, we are employer-led, but we're a multi-stakeholder coalition. So all the different healthcare ecosystem participants are eligible to be members of our coalition, and they sit on our board. They serve as the executive committee, so we have employers, but we also have health plans, we have hospital systems, we have providers, and we have other nonprofits in the community who are focused on similar areas with us, again, based on that quality, affordable, and equitable healthcare. We just had our annual conference in April, and I joined the group as the president and CEO in November, so that was my first conference of planning. And the morning session focused, or piece of it, focused on primary care. I wish I had come here first before we had that particular conference, but we spent a lot of time, several hours, talking about what I'm getting ready to share with you, which is the problems that we're having in Kentucky related to primary care and what employers are doing related to that. But before I get into that, let me tell you a little bit about my role right before taking over the Kentuckiana Health Collaborative. I was a leader within the Kentucky Employees Health Plan for many years, and it is the state's largest self-insured health plan, and it is a public health plan that covers state employees, teachers, the school system administrators, local city and county governments, and then the teachers' retirement system and the Kentucky retirement system when employees retire before they reach age 65 and go on to Medicare. So we had about 300,000, they still have, about 300,000 members on the plan between employees and their family members. And I did that for multiple years. And one of the things from that perspective I want to share is in that role, I took my focus in every decision, and it wasn't just me. There were a team of people I just had the privilege of leading, is everything that is decided about the plan, and it is self-insured, is that one, it has to be a fiduciary responsibility. Some of the things that we're talking about today is, and we were using public funds. And so our employees, some of them made really good money, and some of them barely made enough to make a living, and many of them went off and on Medicaid in Kentucky because their income was so low. So along with that fiduciary responsibility, we also had a personal responsibility, an individual responsibility to make sure that our members had good benefits. And we did have rich benefits. They still have rich benefits. But just because the benefits are rich doesn't mean people understand them or know how to use them. A couple of statistics about Kentucky primary care. So this came, I did learn this information at the conference that we just had from the Kentucky Primary Care Association. So I've heard some numbers in the last couple of days about the workforce of primary care physicians within the different communities. We're 40th in the list of states. We're in pretty bad shape in Kentucky. According to the Kentucky Primary Care Association, we would need 237 new primary care physicians for multiple years to join and serve in Kentucky for us to get above that 40th range. And what I learned as leader of the Kentucky Employees Health Plan through looking at data, not guts, my gut could tell me one thing, and I am personally and professionally an advocate for primary care physicians. Before I ever came to this conference, I think it's an extremely important relationship. But the data was telling us something different about primary care physicians in Kentucky. And so between 2008 and 2016, primary care visits in Kentucky went down 24%. However, specialist visits stayed the same during that same time period, and urgent treatment center visits went up 50%. When we looked at the data around the Kentucky Employees Health Plan, we saw very clearly we had trouble for many years with the emergency room. Getting back to Bret's talk about people using the emergency room as a primary care physician, I too find it horrible when I see a sign that says 9-minute wait in the ER. The ER is not your primary care physician. And we had people, I don't have the exact numbers anymore in my head, but we had people, obviously from HIPAA rules, I didn't know the name of this person, but you could tell within a county. We looked at the data to see within a county at that hospital, we had X number of people visiting that hospital multiple times within a quarter. There's no way that person had that many reasons to visit an ER unless the ER was serving as the primary care physician. And so we knew we had that as an issue in Kentucky. And so what we started doing with the Kentucky Employees Health Plan before COVID was offering free telehealth visits. Now, I'm not saying that brick and mortar primary care is not the best place many times, probably most times, but we had an access to care issue, and we also had an education issue. But getting people access to a doctor, not the emergency room, was important to us from that fiduciary responsibility, but it was also a good benefit. So it was free coverage. This is pre-COVID. Free coverage for medical visits. About 8 months later, we saw that was working very well. About 8 months later, we added behavioral health. And that was extremely important because of the stigma around behavioral health and because most insurance companies in Kentucky, and it could be broader than that, don't pay. The doctors, the psychiatrists, they're stepping away from the insurance companies, and they want the members to pay cash and then file for the insurance. Our members couldn't afford that. And so we saw that being very successful. We also used on-site clinics. We had 4 on-site clinics in Frankfort, Kentucky, which is where most of our population is. It's not where all of our population was because we had members across the state, but the on-site clinics were extremely important. And that wasn't as much as reducing cost as it was about access. We needed members to have access to the care. And then we also partnered with multiple vendors, and that's not always easy to manage. And all of those vendors, we did require every vendor once a year to come to us face-to-face with all the other vendors and share what was going on. We also required, and this was not easy, our PBM and our wellness vendor and our medical vendor to share data. So it wasn't siloed. It was important that that data be shared. We were working on getting the on-site clinics to have that data shared, but we hadn't quite gotten there yet. But it was important that we understood where our population was, and we looked at all of those vendors together. And I mentioned the Kentuckiana Health Collaborative, where I'm working now in our conference that we just had. We had a panel discussion on the issues and what the employers and providers are doing to solve the problem, and then we had a case study. And the employers in Kentucky, what they're looking to are either on-site or near-site clinics, because I believe in what I'm learning. I've learned a lot of the questions that I should have been asking as a leader of a self-insured plan, I've learned more since I've left, but employers need to be driving this. So one question I've thought to ask you, as a primary care physician, what can employers do to help you besides give money? Now, I do think the distribution of money is incorrect. I'm in very much agreement with you on that. But what are some other things? I would love to know what those other things are that we can do, because I don't think any employer out there is trying to dissolve the primary care relationship, especially in Kentucky. I know we want primary care relationships for our members, but we're having to do it in a different way. And we're having to do it with on-site clinics, potentially telehealth, other ways that we're having to do that. So how do we help solve this model, this problem? And one of the things I know that I have written down is there any way the Kentuckiana Health Collaborative can figure out in Kentucky, how do we partner and make sure that we're working on this education piece to get primary care docs not only educated, but then staying within our communities. So that's basically who we are and where I've been and what we've learned about how to solve some of the primary care issue in our state of Kentucky.
Well, thanks to all of you, and obviously the passion is just so admirable for all what you're doing. And Jenny, in particular, I really think it's important, and I'm happy that you focused on your prior position as well, because I think as we see the system moving from fee-for-service in the direction of better value, it's critically important that the public purchasers work in concert. So we watched some experiments out in the state of Washington, the state of Oregon, where they really have done a great job at the state level of consolidating their different purchasing power and driving change beyond the public purchasing arena. So I think it's incredibly important. So, when we hear, again, about like the Medicare system and what they're looking to pursue in the move to value, so much around the triple aim and saving costs. And we've heard you talk about already, a couple of you, about the cost, the line versus the investment. But I think to step back, the one question I think it's really important, and task force members talk about this often, is really what are the outcomes you're looking for? And how do you define success in the initiatives that you're pursuing now? And Jenny, I'll reverse order and start with you on this one.
Well, first, I'm going to go back to that fiduciary responsibility. And part of how we define success is, are we able to contain cost? It's not all about cost containment, but I will tell you that has to be part of it when you're a self-insured plan or any employer looking at whether you're fully insured or self-insured. How are you containing cost? If you're able to get people cared for in an environment that is telehealth or an on-site clinic, and they're going and it's costing you less, one example of containing cost, we started through all of our open enrollment meetings. I traveled, staff traveled, we went across the state. We actually gave them a handout, members a handout, and we did webinars. This is all before COVID. And we showed them what it would cost to go to the ER. We had a good good benefits, but if you weren't admitted, then it did cost you. And then what it would cost to go to the urgent treatment center. The urgent treatment center is not the answer, because that means you don't have a primary care physician. But it is much better to go to an urgent treatment center than to go to the ER. And then what it would cost if you use telehealth. That's how desperate we got to try to contain cost and get people out of that emergency room. So cost, yes, is very important. Another piece of it is we had health risk assessments that people had to do every year, and they were incentivized if they did their health risk assessments. The health risk assessment wasn't just about having someone go take a test. We knew from our claims data people didn't have primary care doctors because of access. We also had people who didn't go to the doctor. They weren't using their health insurance benefits whatsoever. So if we would, but they were paying premiums. So if we did the health risk assessment, they at least had some basic knowledge about their health. You mentioned your LDL level. I'm not sure if you said it was yours. I know you said it was yours the other day. Sorry.
It was mine.
Sorry. But if you're not going to the doctor, you don't know that. So at least by having that HRA, we wanted healthy people. So by paying for that HRA and incentivizing people to get that, that's costing us money, but it's saving us money if we get people then to take care of themselves.
So Dr. Aguilar, same question for you, but I think you have an interesting perspective here because you're working for an employer that's operating in multiple states. So to the extent the question is still about how you define success, is that impacted by the fact that you're operating in a variety of jurisdictions?
Yeah, there is an impact related to the fact that our volume of patients doesn't justify the spread of clinics that might make sense to make it really convenient for everyone. DFW is not, I don't know if you've ever been there, but it's not small. So if you put a clinic in one part of DFW, it's not functionally in the community of a lot of the people who live elsewhere in the Metroplex. So we have a couple clinics in DFW. And we have to think differently about what success looks like there than in a smaller market like Tulsa, where the top of the market to the bottom is maybe a 20-minute drive. So there is an impact of that for sure. One of the unique things that I almost forgot to mention, but I think is really important in this discussion of metrics related to success, one of the unique things about our health plan is that it is genuinely a risk pool. And when I say it's like nonprofit, not-for-profit, for-profit, there's no any residual dollars are returned to the members at the end of the fiscal year. So if the pool overcharged on deductibles and premiums and stuff, and there's money sitting there, it gets redistributed proportionally to what people put into it. So it's a really cool way to say, like, cost containment is definitely important because this is these people's actual money. Like, the people involved in the utilization of the services are actually financially directly linked to that, and we try to be clear and transparent in the way that we talk about that with folks. We have standard conventional quality metrics that really matter a lot to me. Are we referring people of the right age to a colonoscopy? Are we getting people flu vaccines who are willing to do it? All those kinds of things, and we look at that data pretty often. But I'm reminded of, I get to do clerk training for a day at QuikTrip and learn how to actually do the stuff in the stores. They won't actually let me do any more than like the lecture part because they think I'll be too much in the way, which is probably true. But I got to do that training, and in the course of that training, they made a point that has stuck with me forever. And when I give like my road show on redefining quality in healthcare, one of the things that I talk about is what they said there. Now, I'm going to use brand names for the point of it, but I'm not impugning the honor of any brand or representing a preference on behalf of my employer for one soda or another. But the clerk trainer basically said, people come to QuikTrip for a Dr. Pepper. And then he had a picture of a Dr. Pepper. He said, they do not come here for a Dr. Thunder. So if you come to QuikTrip, like, you want the thing that you think you're supposed to get, and it has to meet that minimum quality threshold. It can't be below that. But on the other hand, 7-Eleven also sells Dr. Pepper. So something has to make the person come to us over someone else when both products exceed the desired quality threshold. And that was so poignant and so awesome. And I was the nerdy guy sitting in the back of the room taking like detailed notes at the QuikTrip clerk training, which is probably awkward for everyone but me. But I took these notes, and I really think that's an important concept to have in terms of how do we define success? We define success by satisfying the needs of our patients and satisfying their actual needs in a way that causes them to come back and to stay engaged. My last academic work that I did at WashU was a paper on design thinking and its integration into clinical decision making, and how you can take a UX experience like what they do for website design and think about how we communicate with patients. Someone may come in and say, I want oxycodone. That's what they're saying, and they may be upset you're not going to give it to them because, again, have to meet the threshold of quality. But there's a way to go about figuring out what they need that's past what they're saying, and there's a way to lean on a relationship to try to design something that allows them to have a health encounter that's actually desirable to repeat. And so that's something that we care a lot about. We're in the process of, because we just rolled over the EMR a couple months ago, there's integrations being set for our patient satisfaction surveys. And this is going to be the data that I care very, very much about, because I really want to know that when our employees come into our clinics, we're doing everything we can to make that a desirable encounter to repeat. Because if they won't come back, it doesn't matter if we're making great recommendations. So we need to keep them plugged in. And then we also do care about obvious things like ER utilization. If a market has dramatically higher ER utilization per member than another market, I want to understand that. I want to understand what component of design failure is happening that people are going to the ER more often. You can imagine our workforce is really young, and planning is not, maybe the first thing, planning a health visit. So some of this stuff may be that they just got sick and went right now. But how do we understand how we can pull levers to help with that? How do we democratize the knowledge about the options we have, including telehealth urgent care that's included in their plan? How do we make sure that we're doing all that stuff so that we're balancing the needs they have evenly and taking good care of the money that they're putting in to manage all this risk?
Great. Bret?
They've done a good job of describing what outcomes and metrics that we're looking at.
So you're in agreement?
I'm in agreement.
Yep.
Totally. I'll have one thing to add, and it's about access. It's funny how when you're faced with a crisis or a shortage, your definition of things changes. And we're seeing this not only in primary care, we're seeing it in mental health, is that you're just desperate for any access. Right? And so instead of just looking at, okay, ideally we'd like to have a, physician-led relationship, but hey, our members can't access it, they can't get in, they don't have one that they feel comfortable with. So we look to these vendors, right? We look to these digital solutions. We're looking to, in some cases for women's health, is an OBGYN acceptable for delivering, primary care? The definition changes. And a lot of these mid-level providers come to us and say, okay, we can be your solution, right? And they say, oh, and by the way, if you support us, it'll improve access across geographies. And we just know that they'll end up practicing in the same places that everybody else practices in. They're not going to meet our rural health solutions or anything like that. And so it's just funny how when you're faced with scarcity, you look to other ways to fill needs that you hope can be filled by the ideal solution.
Mm-hmm. So, Bret, follow up for you. So,
can I briefly? Sure. I want to comment on that because I think this is a fantastic and super important point. I don't know if you've read the book, but there's a book called Scarcity by Senthil Mullainathan.
I've not.
This is a fantastic book. And what you're talking about, I think that people want to use payers as strategies for shifting behavior by taking an economic analysis of like, oh, well, what would happen if we lowered the cost here and a rational actor were to make a decision between variable cost items. But the reality of classical economics is that it doesn't sufficiently account for the things like how behavior changes in the presence of scarcity. And I think that when we see irrational behaviors happening, we have to go back and say, what's the driver of that? And I think that I thought you were doing a nice job summarizing the whole book, so maybe you don't need to read it because you pretty much summed it up. But there are predictable moves in the human behavior pattern that will follow a perception of scarcity. And the book goes into talking about it for like farmers around harvest time. It goes into talking about it for impoverished people in different social circumstances. And then it also talks about it in terms of time for executives. And anytime there's a scarcity perception imposed on the person, they're going to change behaviors. And this may be a place where there's really great insights for us to say, okay, we have a scarcity of access to primary care. How do we mine predictable behavior patterns and say, let's get in the way of those and try to make things better? So sorry to jump in, but it was just such a good point.
Great jump in. Bret, I had a follow-up for you on the success question because obviously you have a unique composition within your membership. So is there a nuanced difference, a stark difference between how the labor side versus the management side kind of defines success in this regard?
That's actually a tough question. They're two very different populations. Mm-hmm. Generally, the labor side has a more generous benefit, lower cost sharing, and the salaried side, the management side, has very high deductible health plans. And so we see the behaviors are very different, not just on the perception of what of how the plan can be used, but the way that we access healthcare and our behavioral towards healthcare. Those that are in the salaried workforce are more likely to avoid care, mm-hmm. And they're more likely to. They're still not what I would call healthcare consumers, because we don't have the right information at the right time in an easy form for them to digest. But we're working on it. We're trying to make that better. But on the hourly side, if they need it, they go access it. hopefully, but they still aren't, even though it's very low cost and there's a really low barrier to entry because they have not just a rich benefit package in terms of cost sharing, but they have access to anywhere they want to go. I mean, their Blue Cross card is a passport to every single provider in the state, and they still don't take care of themselves and manage their chronic conditions like they would, even with minimal, if no cost sharing. So the perception of what their benefit plans look like in how it reflects in their behaviors is very different, but at the same time, no one's being a good patient.
Interesting. It's a tough question. It's a tough balance, and we're hearing very similar things in the work that we're doing. So it's really interesting. I know we're all bad out time, but I think if I may just do a quick question. So we have heard a lot of workforce today, and it's really been primarily around shortage, making sure there's access, right? So I know we didn't really prepare for a workforce question in our meeting, but I'm just interested because what we hear at the task force quite often is the desire for employers to push for either coordinated primary care, but even beyond, to advanced risk models, things of that nature. But there's still a competitive element. They want to make sure that recruitment and retention is not impacted in that regard. And so one person very candidly said, well, we are in favor of everything there, but it's really hard for us to go to like a narrow network and put that on top of a high deductible health plan, because at some point that becomes a competitive issue. So just wondering if anyone had a perspective on what you're doing and how that impacts either recruitment, retention. Is that really relevant to the populations that you're serving or not? Because I think that's an important part of workforce that we got to think about too, is designing something so it really does either attract or retain employees. And maybe
Just clarification, you're talking about retaining our employees,
yes,
not, okay.
Yes. Is there any negative impact on what you're doing, is part of the question, currently to advance the kind of the primary care focus? Is that impacting positively, negatively, or net neutral on employee recruitment, retention, any of those type of issues? Is there an impact there?
I think the impact is positive. I mean, at least from what I'm hearing from our employers and to some degree what we experienced with the Kentucky Employees Health Plan. I mean, you don't go into state government to get rich. You go into state government because you have good benefits. And what I'm hearing, GE Appliances is one of our members, and I can say this because they participated in our panel discussion on primary care. And then Louisville Gas and Electric is another one of our large members, and they participated in our primary care panel discussion. Their members are very happy with their on-site and near-site clinics. And in fact, Louisville Gas and Electric is using their on-site and near-site clinics for their family members also on the plan, not just for the employees. And a lot of times you'll just see it for employees. And they shared that they are hearing from their employees and the family members how positive that is. And it does come back to be part of the benefit package that employers are using to sell when they're trying to recruit and retain, because retaining is extremely important, obviously. So I do think what we're trying to do to help people have more access is very important. We're just real quickly, we're doing a grant project in Kentucky with the Kentuckiana Health Collaborative. Several of you have mentioned community health workers. And so I think that's another avenue where employers will soon be engaged to try to either encourage community health workers to be within the different primary care settings or in different settings, or with even in the employer space, to try to help. As I said, I know, and so does GE, so does LG&E, they have employees that even though they have access to employer-sponsored health care, they can't afford the health care or to go to the doctor, and they may even be on Medicaid. So these community health workers can help people navigate some of those social drivers of health. So I don't know if that exactly answered your question.
Other perspectives?
We're in a really unique situation with the way that we're doing things, and what I'll say comes up not infrequently is that there's some tension between a patient and the organization, and so now you've got somebody who has an issue with their doctor who also, by way, has an issue with their employer. And so my job is to be in the middle between that so that patients are protected from feeling like the company's involved in any way. I have like what I consider to be an iron and then fire and then water and alligators and then more iron and fire wall where like I don't want anyone at QuikTrip other than me having any commentary about what we did clinically. It has to stop there. And that wall was actually put in by the CEO, who's very clear that he wants the same thing. If there's some question about, oh, is this or isn't this FMLA eligible, that cannot be connected between the two parts of the organization. So it's got to feel like a concise relationship. But in the eyes of the consumer, they don't know that that's true on the back end. So sometimes you get issues that arise where someone thinks that they're interacting with their employer and doesn't realize this is actually a medical practice and we're functioning as a medical practice. It happens to be owned by the employer, but they're not involved right now.
Yeah.
So there's some of those politics. But overall, I think people have been pretty positive about the plan, pretty positive about the access, and they really, much more than I anticipated, like seeing their doctors in red polos that say QuikTrip. So
Interesting. Bret, last word.
I'm going to venture from the question if I can, although I have a great answer to it. But
Go ahead.
I just want to say to the group and everyone watching is that I think the pandemic was a crisis. It highlighted the fragility of the primary care system and the necessity for change. And I don't want us to miss the opportunity to do something about it. I think we're at a point where we still can hit the pitch. We don't have to watch it go by us. And so I just want to say that I think employers and union purchasers can be partners. We want to be partners. We want our members and their families to invest themselves in primary care. And so just have us be part of the conversation.
That's a great place to end right there. Thank you. And thank you all. And please join me in thanking the panel.